Hello and welcome to Day 2, Session 5 of Rhythm Interventions Online 2025. I'm Jason Andrade from Vancouver, Canada, and course co-director for Rhythm Interventions Online. As always, we have another great session for you. This time we're going to be focusing on best CSP practice. For this session, we have a case presentation for Dr. Amer Abdin from the University Hospital of Saarland, Homburg, Germany, who will join us now. Welcome, Amer. In addition, we're joined by a fantastic panel of experts, including Dr. Usha Tedrow from Boston in the United States, Dr. Atiqa Batul from Scranton in the United States, and Dr. David Zizek from Ljubljana, Slovenia. Welcome to you all. Quick reminder to our audience just to be part of the discussion. So as always, Rhythm Interventions Online is live. And so if you have questions for any of our faculty as we go through this case and this presentation, we would be happy to answer as many of them as possible. So without further delay, I'd like to hand over to Amer for the first part of his presentation.
Thank you, Jason, very much. And it's my great pleasure to be with you today and to talk on conduction system basing. I'm going to start talking about the indication and the current evidence. So talking about CSP indications, we are mainly talking about two main indications. The first one is the basing indication. So we are talking about patients who have bradycardia or AV block and needs a pacemaker. So the aim here is to maintain synchrony. The second main indication is the heart failure indication. So we are talking about patients with heart failure, with bundle branch block, and the aim is to restore synchrony. So to the cardiac resynchronization therapy. And if you want to perform conduction system basing, we have two options. The first one is the His bundle basing, which account around 10% of all our performed cases nowadays. And the second option is left bundle branch area basing, which account around 90% of our cases. Yes, I will start with the first indication, basing indications. And here I will show a short case about a male patient, 57 years old. He has recurrent syncope and mildly reduced ejection fraction, no coronary artery disease with a normal blood values. Here we can see his ECG with a complete AV block. So we all agree that this patient needs a pacemaker, but the question, what kind of pacemaker? Should we go to dual chamber pacemaker with conventional RV basing or CRTP or conduction system basing? And if we look at the guidelines, if we have a patient with high degree AV block, so we have to know his LV function before implanting the pacemaker. And here we have three scenarios. The first one, if the LV function below 40%, so it's a clear indication, CRT class 1A recommendation, regardless of symptoms or QRS duration. And if we have a normal systolic LV function, so we can go to normal dual chamber pacemaker with conventional RV basing. And the question was, what should we do if we have a patient with high degree AV block and mildly reduced ejection fraction? If we look at the recent ESC guidelines for 2021, we can see this small recommendation, and it's written that His bundle basing may be considered as an alternative to RV basing in patients with AV block and LV function above 40%. And the main question, why should we consider alternatives to RV basing? As we know, chronic RV basing, the chronic dyssynchrony lead to systolic and diastolic dysfunction, atrial fibrillation, and mitral regurgitation. Here we call this problem the basing-induced cardiomyopathy, which account around 10 to 40% of our pacemaker patients, according to different studies. And coming to the evidence, which strategy is better, conduction system basing or RV basing? Here we have many meta-analyses based on many observational studies and small randomized controlled trials, which has shown the superiority of conduction system basing over right ventricular basing. Based on this evidence, the HRS published a new guideline in 2023 on cardiac physiologic basing. And here we can see if someone needs a pacemaker and we anticipated high ventricular basing rate, and we have a reduced ejection fraction between 36 and 50%. So we can go either to biventricular basing or conduction system basing, and they both have the same level of recommendation. Also, if we have a normal LV function, so we can go to biventricular basing or conduction system basing. The same, talking about the recent ERA consensus document published this year, if we have a patient with AV block and we anticipated a high ventricular basing rate and we have a mild reduced ejection fraction, so we can go to either biventricular basing or conduction system basing, the same for EF below 40%, and even by normal systolic LV function, we have the option to implant CSP. After the publication of these documents, a new study came out. I will show you three important studies. The first one is a CS-based trial, which was a randomized trial, included 200 patients and randomized to large ventricular basing against CSP, and the primary endpoint was a combined endpoint of pacemaker-induced cardiomyopathy, need for CRT upgrade, heart failure hospitalization, and all-cause mortality. And here we can see the significant positive difference for for conduction system basing over right ventricular basing concerning the primary endpoint and all its components. The next important study was recently published, a Mellosh Reload study. It was a observational study, included more than 3,000 patients with AV block and LV function above 40%. And the primary endpoint was all-cause mortality in propensity match groups. And here we can see that left-bundle branch area basing showed a significant lower long-term mortality compared to right ventricular basing. And the last study presented this year during the ESC Congress, it was a registry-based randomized trial, included young patients younger than 65 years old, and the patient were randomized to left bundle branch area basing against right ventricular basing. And after 2 years of follow-up, there was also a significant positive difference for left bundle branch area basing over right ventricular basing concerning the primary endpoint, which was a combined endpoint of cardiovascular mortality and heart failure hospitalization. Although we have many positive studies, we are still waiting for the large randomized controlled trial. There are many trials running right now, and we hope that we can know more during the next 2 to 3 years. Yet moving to the second indication, heart failure indications. We start with the main question, why should we consider alternatives to biventricular basing? We have different reasons, for example, the CRT non-responders, failed CS implantation, the benefit in non-left bundle branch block patients, and narrow QRS complex. The main disadvantage is that we don't have a large randomized controlled trial by 2025 for conduction system basing, and which shows the superiority against biventricular basing. We have many small randomized controlled trials, and here we can see the number of the patients included in all these studies. And we have the meta-analysis, including this 5 randomized controlled trial, and we can see the positive significant difference for CSP against biventricular basing regarding the QRS duration, improvement in LV function. There was no difference in basing metrics or procedure time, and also there was no difference in complications. And talking about recommendation here, we are going to show you the HRS recommendation if we have a patient with left bundle branch block and LV function below 35%, wide QRS, symptomatic. So we can go to CRT, biventricular basing, class 1A recommendation. And by failed CRT, we can move to CSP. And if we have a patient with LV function above 35%, between 36 and 50%, wide QRS and symptomatic, so we can go either to biventricular basing or conduction system basing. And we have also new data came out during the last 2 years. For example, this study was published in Heart Rhythm, included patients with HFrEF and CRT indications, and in each arm, 780 patients were included with propensities also match groups, and the primary endpoint was heart failure hospitalization, which was positively significant and for left bundle branch area basing against biventricular basing, the same for echocardiographic outcomes. Recently, the consistent CRT trial was published, which was a non-inferiority trial, compared CSP to biventricular basing, and the primary endpoint was combined endpoint of all-cause mortality, cardiac transplant, heart failure hospitalization, or LV EF improvement below 5 points. And here we can see after 1 year of follow-up, the CSP was non-inferior to biventricular basing. And Talking about the recent ERA document, we can see if we have a patient with CRT indication and left bundle branch block and AEF below 35%, so we can implant either biventricular pacing or conduction system pacing. The same for AV block. We are still waiting for the large randomized control trial, and hopefully in the next 3 to 4 years, we will know more about CSP against biventricular pacing. Just briefly talking which better, his bundle pacing or left bundle branch area pacing. I will show you a recent meta-analysis included 10 studies with more than 1,500 patients. And here we can see that left bundle branch area pacing was better, talking about implantation success rate, pacing threshold at implantation, and follow-up procedure time. So to conclude, CSP is a very promising technique, and large randomized control trials are needed to prove the clinical outcome. However, while waiting for the result of large randomized control trials, CSP should be considered as an alternative to right ventricular pacing in patients with AV block and LV function above 40% or in pace and ablate strategy. Talking about heart failure indication, CSP should be considered as a treatment option in patients with failed CS implantation, with wide left bundle branch block and LV function above 35% with simpler device, so single or dual chamber, or according to implant experience as a first choice for HFrEF and left bundle branch block patients. With this, so I finished my first part of my presentation. I'm happy to take questions and or any comments.
So thank you very much, Amr. That was a fantastic review of the evidence and the indications. There was a lot of information presented, and all of it very forward-looking, and it's good to have a good sense of where we're going as a community. I guess before we get into your case presentation that you're going to have, I thought it would be good to just take a moment to poll the panel and get their thoughts in terms of what they're doing right now in terms of CSP versus CRT versus standard RV pacing. Maybe I'll start with Usha.
Thanks so much. That was a great presentation and a great summary. I think what we're doing sort of right now is for like patients who present even with AV block and relatively preserved ejection fraction. I think that we're all asking ourselves why not to put in a left bundle area pacemaker at that time. So I think our practice has definitely moved in the direction of using that technology. I think for the low ejection fraction group with left bundle branch block, I still tend to go a little bit more for the coronary sinus lead, partly because some of those patients, it's an upgrade from an existing ICD. And I've had some patients where having a right ventricular apical ICD lead and then adding the conduction system pacing lead has worsened the tricuspid regurgitation for those patients. So I sort of tend towards the CS lead first for those particular patients, but definitely go back and forth depending on which is more feasible and where the scar is for those patients with cardiomyopathy.
Atiqa, what about you?
Yes, so I am at Geisinger, which is, considered to be one of the bigger conduction system implanting sites. And so for us, obviously, there's a little bias towards it and pretty much attempted in all patients. And I think that's also counted towards the proficiency that all our operators have acquired just from the sheer number. But I tend to agree with Usha in terms of cardiac resynchronization. We tend to take a very structured approach to it. Starting from the EKG, whether it's typical or atypical, looking bundle branch block. If we are going to are in the favor of conduction system pacing, then we try to go through the steps to make sure that we have appropriate conduction system capture. And until and unless, you're sure of that, you wouldn't do the patient a disservice. And oftentimes I've put in BIV, especially if I'm ablating a node, whereby I've given them a CS lead on the side. And again, there are patients with diffuse disease where a lot CRT is needed. And just by putting a proximal conduction system lead is not going to help them. So I think we tend to take a more academic structured approach whereby if we are leaning towards conduction system pacing, then there has to be a strong reasoning for it.
And David, how about you?
Yeah, I would agree with both panelists. So The AV block population, we tend to go to CSP quite often. Of course, the 6 sinus patients do get still a standard pacemaker, but AV block patients, we tend to go to CSP, particularly left bundle branch area pacing. For the pace and ablate strategy, we mainly use CSP because particularly left bundle branch area pacing, because it's the most convenient one lead. And of course, the
Option.
ablation part is not an issue because of the distal position of the lead. Regarding CRT, yeah, absolutely. We've done a randomized study we just published in Europace, and we are still being very cautious, especially if you're considering only one lead, so LBB correction, with a very specific patient population with Strauss criteria and so on, indicating a proximal block. But to be honest, now our strategy has changed into more of a approach. If we are not completely sure, let's say, there are indications of proximal block, we go by V, absolutely. In other patients, we tend to check if the LBB corrects it to a level that we are satisfied with activation, left ventricular activation time nearing physiological levels. Otherwise, we perform lot CRT quite a lot, although we're still with my colleagues discussing because of the length of the procedure. So to be honest, 60%, I'd say, ventricular still, and only with those that are very absolutely sure and maybe a bit older, that we can use a normal pacemaker with left bundle only, otherwise lot CRT. Yeah. This is our approach. We are being cautious despite of the positive data that is coming, but we also need to consider long-term results which still haven't obtained. So I think this is our approach.
So I would say, in Canada, we just recently published our Canadian Cardiovascular Society device guidelines, and over the year too that this was developed, there was a lot of discussion. I mean, we have, polarizing opinions across our country where people think that, every device should be CSP at a default, and, RV apical pacing or septal pacing or standard pacing should just fall by the wayside. And others take a more cautious approach just due to the question around the long-term data and the randomized data. So, I think the opinions are still quite broad across our community, and it's important to, continue to generate the data to inform what we do. So maybe now is a good time to transition into Amr has a case he's going to present. And so I welcome the questions online. So remember, you have that box here to ask the panel throughout the session. If there's any questions as the case goes by, I invite the faculty to, have the discussion here for the next 14, 15 minutes. And then afterwards, we'll have a Q&A to address any questions that come up.
So after this nice discussion, I think it's nice to present this case. Johan, just to quickly present our teams, Dr. Al-Masri, our staff here, Johannes, Ilka, and Stefan, and Vladislav, both from Boston Scientific. And now you can see the slide of my case. So it's about a lady, 77 years old, and she underwent a TAVI for severe aortic stenosis 8 days ago. She has a non-paroxysmal AF, and she experienced many pre-syncope events in the last 2 days. Here we can see her ECG before TAVI, a normal sinus rhythm, normal AV time, and a normal QRS duration. And after TAVI on day 1, she developed a new left bundle branch block with a QRS duration of 130 milliseconds. And here we can see on day 3 and on day 7, she experienced a further prolongation of her PR time. Then the last PR time was 270 and a QRS duration of 140 milliseconds. Her Holter ECG showed many AF episodes with a heart rate up to 170 beats per minute and intermittent 2-to-1 AV block. Then, what was the next slide? And here we can see her echo with she had a mildly reduced ejection fraction with AEF of 48% and a left ventricular end diastolic diameter of 48 millimeters. So based on this finding, we decided to implant dual chamber pacemaker due to her progressive AV conduction delay, symptomatics, the pre-syncope events, and the high risk of complete AV block after TAVI. and our chosen approach was left bundle branch area pacing. We decided to perform the procedure with the material of Boston Scientific. And as you know, we have two options, two catheters, the SSPC 2 catheter and SSPC 3 catheters. It depends on the indication. If we have a patient with heart failure indication, dilated LV, so we're gonna start with catheter number 3. If we have a patient with a mildly reduced or like not dilated LV and mildly reduced ejection fraction or normal systolic LV function, so we can start with catheter number 2. Here in our case, the patient had an LV function of 48% and LV and diastolic diameter of 48 millimeters. So the catheter has been flushed. And then we use a long wire and we put the catheter over the wire. Here we did an axillary puncture to have the access. And the first step is to enter the right ventricle. So here we can see the TAVI, the valve, implanted 8 days ago. And here the first step is to enter the right ventricle using the wire. And then now I am in the right ventricle, so I will push my catheter and then I will put back my wire. The next step will be the lead from Boston Scientific is the Ingivity, the normal basing lead, 59 centimeters. So we'll insert the lead and I will push my lead before the end of the catheter. Then I will deploy the helix using the normal helix tool. I will rotate around 10, 12 rotation. And after that, I use the locking helix tool from Boston Scientific. Again with stylet.
Here you have the TAVR valve to guide you, but in your practice, do you use contrast or do you map the His when you're using Boston
No,
Scientific or styler-driven leads?
in general, or maybe sometimes we are not sure we could use contrast. We don't map the His. And then the next step will be sure that we are looking at the septum. So we look at the RIO. Here we have the valve. It's a very good marker. So we know that around 2 centimeters below the valve. And if we look at the LAO, we have to be sure that we are perpendicular to the septum. And here we are looking at the septum. So I will like perform mapping to see if I have a signal. So we had a good signal. So also I pace here and I saw the morphology of the QRS. It was we had a W wave pattern in V1 and positive QRS in 2 and negative in 3. Then I will start rotate the body of my lead. So 5, 6 fast rotations to penetrate the septum and overcome the right side of the septum. So here fast 5 to 6 rotations. And then I perform my first measurement. Here we can see here native ECG, and here we pace and we see the morphology in V1. We have a W wave morphology in V1. And that's all my initial impedance was around 800 ohm. With a good current of injury. And then I continue rotating my lead and looking at the ECG and at the same time looking at the impedance and the current of injury. Here I continued rotating my lead, looking at the morphology of the QRS in V1 and to see if there is any change in the morphology, and looking also if I have any fixation bead defined as right the branch block PVC with a narrow QRS. Yes, I continue rotating my lead. And then here I notice a little bit difference in the morphology in V1. Then I continue also rotating the lead, and I noticed the QRS is a little bit narrower. Here we can see also on V1. And here we had a 1 PVC with a terminal R raise. Here we had also a narrower QRS. So I continued rotating my lead, and the impedance was stable. So it was around 700. And then I noticed one fixation beat and then a terminal R wave in the QRS in V1. Here we can see the terminal R wave in V1. So we are basing from the left side now. And all basing metrics were also stable. We have a good R wave. It was around 9, and the impedance was around. It's a little bit. We experienced a little bit drop in the impedance, which was expected. It was around 600 because maybe we reached the subintercardium from the left ventricle. Here I did also 2 other rotations, and then I performed my first measurement. The first thing I looked at the V6 to look if the airwave peak time. Which was 70 millisecond.
What output was that?
5 volt.
Okay.
So
then,
one question.
Yep.
So you don't. One question. Do you have any additional? So if I understand correctly, you measure the unfiltered signal on the PSA. You don't have it disintegrated in your EP tracer.
No, we don't have an EP tracer. That's why we have only 12
okay.
lead ECG.
Yeah,
That's why I want to
Understood.
show how you can
Okay.
simple do it. I say because
Mhm.
so many center we only have like 12 lead ECG, and that's why I want to show how we do it on these settings. So we measured the airwave peak time V6. It was around 70 milliseconds. So we performed the threshold test to see if we have a transition from non-selective to left ventricular septal pacing or non-selective to selective LVP pacing. And now we can see the outputs 0.2 or 0.2, around 0.2, 0.3. Then we performed the measurement again. So we look at the airwave peak time in V6 to see if there's any prolongation using the low output. And it was also stable. It was 70 milliseconds.
And what was your unipolar impedance here?
It was 600. Here you can see it's 700 here, I'm sorry. 700 on the left side. It was 700 ohm. So a little bit decrease in the impedance, which was expected. And then here it was 70 milliseconds. So it was no transition in V6. So we look at the airwave peak time in V1.
Mhm.
And here it was with 0.2 volt, it was around 100 milliseconds. So we go for a high output. We went for the high output and also performed all measurements again. And we see that the airwave peak time in V6, it remained also stable all the time. It was 70 milliseconds. And according to the ERA consensus document, if we have a native wide QRS below 80 milliseconds, it will be optimal. And it was 70 in our case. And here the airwave peak time in V1, it was 90 with higher output. So it's a kind of transition from non-selective to selective LBP basing. And then
EKG wise, I'm not able to appreciate, but yeah, if you saw transitions, those are important transitions.
Yes.
So with higher and lower output.
Yes, this is a more specific sign, to be honest, to be sure that we are capturing the conduction system. And we expected, and here we can see the QRS duration looking at the speed 25 millimeter per second. It was really narrower compared to her native ECG. And we measured also the duration of the QRS. Here we can see her native ECG, which she had a left band branch block with a QRS duration of 130 milliseconds. And the QRS duration was, her native QRS duration was 130, 140 milliseconds, and under stimulation was 100 milliseconds. So, I mean, as we also look at during the threshold test, if we have a transition, which defined, as you know, prolongation 10 to 15 millisecond in the airwave peak time V6, or 10 millisecond in airwave peak time V1. And here we always experience 10 millisecond prolongation in airwave peak time in V1. So it's a kind of transition from non-selective to selective left bundle branch basing. And the QRS duration was under basing was at 100 millisecond. And her native QRS was around 130 to 140.
Yeah, and also we can observe nicely the drop of current of injury, which
Yes,
indicates that
you're
we're
right.
definitely in the left endocardial area. I'm sure.
Right.
I'm not completely sure
Yeah.
that we are actually seeing the proof of conduction system engagement. But if you can, we can also observe before the main curve, we also see a small bump, which could indicate the injury of the conduction system in the current of injury panel. But I'm not completely sure, but definitely in patients after TAVI, yeah, it's a good, LBB is a good strategy.
So I totally agree with you. I mean, we experienced two things. The first thing is a drop in impedance. I mean, we expected to have an increase in impedance when we are in the deep septum and when we reach the subendocardium from the left ventricle. So we expected to have a drop in the impedance, but not more than 200, 300 ohm. So in this case, we started with an impedance of 800 something, and we end at our end. The final impedance was around 600. Second thing, the current of injury, as you said, it was a little drop in the current of injury, which also is expected when we reach the subendocardium of the left ventricle. Talking about electrical parameter, I mean, only using the 12 lead ECG, what can we measure? We can measure the airway peak time in V6 and look is the time, and then also look at the transition during the threshold test. And then we have to see the prolongation in V6 or in V1 and to decide if we have a transition from LV, like non-selective LV septal or non-selective to selective basing, and also the duration of the QRS and the morphology. And as we see here, my QRS was positive in 2, negative in 3, positive in AVL. So it's a kind of posterior fascicle, something like that. So, and then the next step was to slit the catheter. And it's a very important step because after slitting the catheter, we have to be sure that there's no micro dislocation or any kind of lead movement. Then here we check the position, which was stable, and then also I performed a measurement again to be sure that.
Just one quick question: you put the
Yes.
you don't retract the helix while slitting the catheter. You leave it as it is. Usually,
yes.
the stylet.
Yes, because
okay.
Yes, I start as it. Yes. I know that many people like do like that. For me, I will slit the catheter, and after that, I will control the position of my lead. It was really important for me to look at the ECG at the end, to look at the morphology and all measurement. And here we can see here native ECG, and then I will paste. This will start, I hope. Yes, okay. So after slitting the catheter, so we have the same morphology and the same duration of QRS complex. So I mean, I'm working in very different countries, and to be honest, is many different countries you only have the option to have 12 lead ECG and no other like EP system, any different things, and that's why. But we have to sure at the same time we have to be sure that we are performing like in a good quality and to have a good measurement and to have a nice result. And all talking about all documents, the most specific sign is the transition. If we have a transition from non-selective to selective or non-selective LV septal basing, so it's 100 specific to know to say I have a successful LBP basing case. Of course, we can look only at the airway peak time in V6, which also with around 90% specific. Also the difference between V6 and V1. So airway with many other parameters, but the most specific parameter is the transition. And so I just to summarize the case as I show you, I start like first of all I start with the position to know that I'm looking at the septum, so RIO and LAO to be sure that I'm perpendicular to the septum. Then I perform mapping to see the signal. Then I will rotate my lead 5-6 fast rotations to penetrate the septums, and we experience maybe the impedance will go high during rotating the lead, and when we reach the subintercranial of the LV, then we experience a drop in the impedance. And then I will also look at the morphology of my QRS during rotating. And when I see a fixation beat, I will be slow. And then if I have a terminal RV, so I know that I'm pacing from the left side, it's a question, it's the question, do I base from only the muscle, or I'm basing from the left bundle? So I have to measure the airway peak time V6. Then I can perform my threshold test to see if I have any transition. And of course, we look at the QRS morphology and all other parameters. And yes, maybe I can show you the ECG after implantation. Can we stop the case and go to the second presentation? So here we can see the ECG 1 day post implantation. That was here ECG before implantation. We can see the AV block, the first degree AV block, and the left band branch block, the QRS duration of 130 milliseconds. And here after implantation, we can see the same. We have the terminal wave, we have the narrow QRS, and the positive and 2, negative and 3, and the positive AVL. That was the ECG after implantation. So do you like to comment?
Axis almost, your axis almost looks normal. AVF is positive, 2 is positive. I think you're not that much biased towards the posterior fascicle in terms of if I look at the inferior lead, so it looks okay. Yeah, that looks good.
Yeah.
I think Dr. Oscar Cano also came up with the ECG criteria, which was recently published in JACC, whereby you can use, that upstroke ratio.
Yes,
Upstroke
the fast, you mean
that's
fast,
helpful
slow.
in some cases. Yeah.
Yeah, I think we had
fast and fast slow. Mhm.
because I think what we had is a fast slow. I think to not look back, we had a fast what we are stimulating from the conduction system, and then slow. So that's what the ECG after implantation. And so I mean we are working at the University Hospital in Germany, and we only have this option. We have this 12 lead ECG in our pacemaker lab. So, however, we are still able to perform a good LBB case. That's why I wanted to show this case. And also, as proctor, I think many of you, I'm Syrian, and I'm implanted many left band branch cases in Syria, where we only had this opportunity, maybe 12 lead ECG. That's why we have to be sure using this material that we are performing a good LBB case. So, just moving to the next part. As showed, I use material from Boston Scientific, and we have many options talking about the catheters. In general, we are using the number 2 or number 3 catheters. Yes, there's a new development from Boston Scientific, the NXT catheter and NXTY catheters. The difference is the length of the curve and the length of the catheter. Talking about the lead, we have one option approved is that Ingivity plus lead, and this lead was. And just come back to the catheter. There's a nice paper published in JACC EP. Here we can see how can we decide, depending on the indication. If we have someone with a heart failure, so we can start with the 3 catheter. If we have someone with a normal heart, so we can start with the catheter number 2. The longevity was studied in the inside LBB area registry, which included around 1,100 patients. And first of all, we can see the implant success rate, which was very high, was 96%. And the primary endpoint of the study was the efficacy of the lead. It was measured by the maintenance of the capture threshold during follow-up and the airway sense amplitudes. And also the safety endpoint was also very important at 3 months, which defined as lead-related complication, freedom from lead-related complication more than 90% during the 3 months of follow-up. Here we can see the lead-related complication free rate, and this was 97.2%. And talking about basic metrics, talking about threshold, it was stable during follow-up, and the same for R wave amplitude. Complication is really very important. Maybe we can talk about dislodgement, which only 23 cases, and the majority of cases or the dislodgement happened during the 7th day after implantation. And now we're using the new helix tool. I think it's very important things because we can prevent micro dislocation and to be sure that the helix will be retracted and remain stable also during follow-up. And just to the question, which lead should I use? Should I use stylo-driven lead or lumenless lead? We don't have only one randomized control trial compared the post strategy, but I will show a meta-analysis. We performed and included more than 12,000 patients. And here we can see there was no difference in implantation success rate, also in pacing threshold, hour amplitude, pacing impedance. It was shorter, a little shorter using the study-driven lead, talking about procedure time. However, the rate of complication were higher in study-driven lead group and were lower in lumenless lead. And we are talking about two main complications. The first one is the fracture, and the second one is the microdislodgement. I finished my second part. I'm happy to take your questions and all your comments.
All right. So thank you so much for those, the case presentation and the didactic presentations at the beginning and the end. I mean, I feel like I learned a lot, so that's fantastic. We have a little bit less than 10 minutes left for the session. For those online, please remember you can submit questions. There are a few questions here that I think I'll maybe just ask the panel about their thoughts as we kind of get through this last little bit. So, as the case was being presented, we heard a comment about the possibility that you're engaging one of the fascicles. And so one of the questions that was raised, I'm just going to take it a step back, is whether or not there is outcome differences that we know when you get deep left septal pacing versus left bundle branch area pacing. And does that change the outcome in terms of what we see with patients?
So
I don't know if someone wants to answer that. Amr, maybe you.
I think yes.
So,
I think of course there's a clear difference talking about LV septal pacing and left bundle branch area pacing. That's a clear difference between the post strategy. Left bundle branch area pacing is significantly better. I mean, because they're talking about a hard endpoint, we don't have a randomized control trial, but we can have larger studies showing the superiority of left bundle branch area pacing over left LV septal pacing. So that's why it's very important to be sure that we are capturing the conduction system and that we are performing left bundle branch area pacing. At the end, LV septal pacing is better than RV pacing that we know, but it's not good enough as the left bundle branch area pacing. So left bundle branch area pacing is significantly better than LV septal pacing.
If I may add a couple
Okay,
of
so
quick
then-
points to that.
Sorry.
If you look at the PhysioSync, which came out where CS was superior
exactly.
to CSP, you had 18%, LV septal pacing. So definitely when you're looking for cardio synchronization, you have to make sure that you have conduction system capture at implant and during follow-up, because there's lead retraction, movement, all of those points are important.
And I would add
Okay,
to
so
that.
now-
Can I just add a few thoughts?
David, go ahead.
The approach that Amr showed, I can agree with. Of course, not every hospital has the tools and the recording system and so on. But for the broad indication, I would say this approach is feasible. I agree with it. But for CRT indications, I must say that EP recording system is relatively very good tool that we can actually approve engagement of the conduction, which is important, as was mentioned. PhysioSync showed us that if we are not prudent, if we are not proving the conduction system engagement, we can do worse than biventricular pacing, which is a good therapy.
Okay. So now to elevate it a bit further in terms of, I guess, the EP conversation. So fascicular pacing prioritizes activation of one fascicle over another and may actually be a little bit more relatively dissynchronizing for the left ventricle, but also can dissynchronize the right ventricle. So in the question here is like, do you feel if we're trying to do CSP that fascicular pacing is associated with inferior outcomes compared to direct left bundle engagement, or do you think it's good enough?
So our approach is, always to try and figure out, because as we know from the data, most of these blocks are more proximal. So his bundle pacing, if you have a right bundle delay, if you correct the right, obviously there are trials underway, his CRT included, but we try and aim for the proximal bundle and try to cause less dysynchrony. However, we can get some right bundle correction with the anodal capture also. So that's also something to consider. If you can't get proximal bundle, or you're not adept at, getting a good His bundle pacing with correction, then I would say getting a fascicular capture, which even in the Malos trial, they had left posterior fascicle and they were captured mostly, and there was no difference in outcomes. So I think it's still acceptable. But again, I would say that you have to make sure that you have conduction system capture, and two, the patient doesn't need a lot CRT, like more diffuse disease.
Totally agree.
The anodal
Because
capture comment is really interesting. I thought the anodal capture concept. How do you guys typically program the device? Because we did a lot of the testing, even in the case, unipolar. And in the end, I'm guessing that 12 lead you showed us in the end was bipolar pacing
bipolar,
from the
right?
because I didn't see a very big pacing spike. So do you try to exploit the anodal capture part to get more of the RV involved earlier? Or do you if your unipolar pacing from the tip of the lead looks the best, do you use that instead?
So maybe I let me say I try like tested the both after implantation and to see how the QRS looks like, and then I will decide depending on the morphology of the QRS. For example, here we decided to go for a bipolar pacing because it was really narrower, and that's why we said, okay, maybe we have a little bit RV activation or something like that. That's why we try to program it as a bipolar. However, sometimes we look at the morphology of the unipolar. If we see a very good terminal R wave with narrow QRS with a unipolar pacing, so we'll go for unipolar. I don't know how do you do also in your daily practice.
To be honest, I was setting everyone to bipolar at first, but then when we were start to having some concern regarding microdislocation and how to actually recognize it during follow-up, now we're setting it more to unipolar, because since in a lot of cases this is the only way you can actually recognize that there has been a microdislodgement and let's say conduction system engagement is not there anymore. We have only LV septal or even worse deep septal. So that's the issue. That's the reason it's why we are setting it to unipolar, not so much in a hemodynamically or electrophysiological reasoning, but more of a follow-up reasoning. So I have no data to confirm this is the right setting, but this is why we do it.
We do also unipolar to be able to recognize, but as Usha was pointing out, and sometimes I've seen a bipolar correct the right bundle delay or shortening the AV to pre-activate the RV, and then I keep bipolar. But one of the instructions that we have in our device clinic, which is very specific, is that the nurses or the device nurses know that they have to check unipolar and bipolar with EKG transitions every time the patient comes for follow-up. I think that's very important.
We perform the same. That we always test the both, I think.
All right. Well, I think it's coming up on time to draw the session to a close. So I want to thank Dr. Abdin for an amazing case presentation, as well as those presentations of the didactic material and the evidence. And it's my pleasure to have had Drs. Tedrow, Drs. Atiqa, Batul, and Dr. Zizek here to provide their expert commentary. I'd like to remind everyone that RIO 2025 Day 2 will continue. And for the next session, we will hand over to Dr. Richard Schilling in our London studio. So please stay with us.
Thank you very much.